Thank you, Chairman. I think I will try to cover in 5-7 minutes so that we have some time for discussion. We all are aware about the need for transforming the medical education, and indeed today's topic is redefine medical education. So I will concentrate on the medical education and can we redefine it. That will be my main issue. So when we are telling rural and urban divide, why the divide? We already have discussed, but the point that I feel is unwillingness of doctors or health personnel to go to the rural area. We have already discussed why they are not going. Inadequate facility and equipment, inadequate or absence of referral system, modern system of medicine versus Indian system of medicine. I think already Ayurveda and homeopathy is already discussed. I think we have to concentrate there also. Why doctors are not going to the rural area? As we interact with our colleagues that who are posted in the rural area and what are the problems, I find the main issue is the social factor. My colleagues, even he is the best graduate of All India Institute of Medical Sciences in 1983. They formed a team. They are working in right now in the tribal areas of Bilaspur, that is Chhattisgarh. And last week, some of the colleagues, he told, I am bringing my son for admission to the school in Delhi because he has now gone to class 11 and he cannot find a school in Raipur. So in spite of all the willingness to go to the rural area, one cannot remain there because of the main issue, the education of the children. I find that is the single most important factor why a motivated doctor is not going to rural area. Forget about the unmotivated people. The other facility like water, electricity, transport, these are the basic problems. Inadequate training. I find another factor, forget about the social side. I find our training is not adequate to make the doctors face the rural challenge. It is very easy to conduct an operation or do some procedure in a medical college setup where there are a lot of senior doctors to help you. But even a small procedure independently doing in a rural setup in a constant situation is very difficult. Therefore, training in resource constraint, we are not training our doctors. I think that is a pedagogic defect. Another is public health approach. Whenever we are seeing a patient, we go as per the battery of laboratory tests that we have been discussing in the last session also. Can we have minimum facility and minimum investigations to reach to the similar diagnosis? May not be 100% correct, but maybe 99%. Can we develop those approach? That is the public health I am telling, and the attitude. And we are talking today about the bridging the divide. But my issue is divide a must? Should we allow this divide to exist? I feel this divide should not exist. Will treatment be different for same disease in rural or urban area? Should quality of care be different because it is rural or urban area? Should affordability be an obstacle for right to life? If these are the basic issues, I don't find that there should be a divide. It is our failure to create enough number of doctors, our failure to create enough trained personnel to face the challenge. And we are creating divide and we are trying to solve a problem which has been artificially created. We should have a totally different approach that we will not allow this divide, rather we will utilize the present day technology, present day approach so that everyone is taken care at par with quality health care. Is it possible? Therefore, the issue is not to bridge, rather to abolish the divide. Can this divide be abolished? What is the requirement for abolishing this divide? Create adequate number of trained health personnel, equip the peripheral health setup, streamline the referral system, research and promotion of the Indian system of medicine, and reform the social sector. I will take only one issue out of that, out of all these, which is the mandate for today's session, redefining medical education for capacity building. The issues that we have to deal in this topic, trend of super specialization, neglecting the skill training at MBBS level. Because we know, okay, in MBBS he has not learned, he will learn in the MD. Or a student feels, no, I am going to do MD or cardiology. Even if I do not learn my skill, I will learn later on. This attitude has diluted the quality of training at the undergraduate level. Neither the teachers enforce it, nor the student is interested. He is more interested to prepare for the entrance test rather than learning the skill in the internship. Limited capacity of training at medical college. That is again limiting to the number of doctors to be trained. No provision of training in the resource constraint I have already highlighted. The doctors, a fresh graduate, if I tell and post him in the rural, he cannot do it without doing further residency or further experience. And there is no provision of CME, which has been already highlighted. Then how to solve this? These are the problems we are talking. But can we redefine the education? And this approach is, I am telling, pedagogic approach to medical education. We have to totally look the pedagogy in a different frame of mind. Then only this solution can be solved. And what is that? It's a very simple process. We all have been trained, or any skill training, basically 4 steps of learning. Read the text, get the demonstration with the discussion, practice under supervision, then self-practice for self-confidence. These 4 can be built into a model that cognitive learning, we have dealt in detail last session, even this session, the anatomic demonstration, all these things. The cognitive part can be done very well through e-learning or through video lectures, anything. We needn't worry, we don't require a medical college teacher, and we don't require a residential posting that he has to be in the full-time student for cognitive learning. What is required is for the skills and the attitude, the psychomotor and the affective domain. For that, we have to have medical college, and what I am advocating today, that we have to link to the secondary health setup. We are restricting our training because we have not expanded our infrastructure beyond medical college. We have created a divide that he is an academician, he is not an academician. He cannot communicate because he is not an academician. I think we have to relook to this strategy. What I am talking, I will just quickly finish it so that we can discuss more. That if we create district hospital as an academic hub, then what will happen? We are expanding, we are not creating any facility. Facility is there. We are expanding the utilization of the health infrastructure for medical education purpose. And we are creating a network of institutions which will automatically streamline the referral system. Because if my student is going to a district hospital, if there is a referral, it will be taken care definitely, because it is part of my own network. Learning material, that is the patient, it is available in the periphery more than in the medical college. We are utilizing our clinical material. Learner-teacher ratio will be automatically taken care, like it was highlighted. The teacher-learner ratio 1:20, from 1:10 or something, it was highlighted in some presentations. We can increase the teachers by enrolling the experts available in the periphery into the education system network. And optimum, therefore, we can have the optimum use of the medical college teacher, like he was telling a cardiologist seeing a URI. It is ridiculous. We can utilize if we do in that way. Peer group competition. For example, in a medical college setup, if the MCI increases seat from 100 to 150, patient load is same. That means you are having competition within yourself to see a patient or to have a procedure. So that competition will also not there if we divert some of the training to the district hospitals. It is really a torture of a patient. If all a group, like 6 students, they are told to palpate liver, all the 6 will palpate the liver, and that patient will tell, I don't want. This is a reality we all have faced. So this torture will be no more there. In the vice versa, what will happen? The patient care will improve in the periphery. Because more doctors are going there, more time is invested for those patients who are not being seen in a district hospital. And there will be physical workload of the doctor who is seeing in a periphery. He is having more hands. His workload will decrease. And all the above things will bring patient satisfaction in the periphery and confidence in the peripheral setup, which is not there today. Therefore, they are coming to the medical college. But if we divert some part, the confidence will build there, and there are other benefits also. One-to-one learning. In a group, peer group learning has an importance, but one-to-one learning has also an importance to clear his own doubts. That is the possibility that will be possible there. And for PG level training, postgraduate level of training in distance education, all those things, even leave is not required, they can be trained there itself. CME will be inbuilt, because if we involve periphery doctors for teaching, they have to update themselves. CME becomes a compulsory or automatic phenomena for themselves. and training will be more cost effective. There are so many parameters. I am not touching those parameters. If we create district hospital as an academic hub, all the problems that we have highlighted in our last 3 presentations, I think it can be taken care. And IGNOU has already experimented. I am not telling anything theory. We have experimented in IGNOU, so many programs we are offering, and we have adopted this model to some extent, not fully, but some extent. What are the programs we are giving? PG diploma in maternal and child health, PG diploma in hospital management, rural surgery, geriatric medicine, community cardiology, oral implantology, endodontics, HIV medicine, dialysis medicine, diabetic medicine. So these are the programs we have already experimented, and we find it will work. And if it is done at a national level with a planned effort, with the networking of the medical colleges and the district hospitals, I think it will be a tremendous success to create the manpower, trained manpower with an affordable cost in a short span of time. And that is what I tell, developing district hospital level hospital as academic hub holds the key to the change of health scenario of the nation through enhanced training capacity, training in resource constraint, inbuilt CME, and streamlining the referral system. Thank you.